All right. Welcome to the fourth episode of NST Things. This is Casey Smith, and I have a few interesting cases that I had this week. Some kind of powerful emotional things that had happened with a patient that just happened to come in who had lost a son. Also another patient I kind of made a breakthrough with who had been through a very traumatic car accident and very extensive reconstructive surgery, and another patient who was referred in just recently and just had some interesting things kind of come up in her case. She's an interesting case in and of herself, but being able to go back and reference certain things helped tremendously with me better explaining her kind of current predicament. So I guess we'll kind of start with Monday. Monday was a pretty typical day, about 8 patients, and I had a bit of an unusual day in the fact that I had 3 new patients, and they were all in the afternoon. That typically never happens, the 3 new patient parts. New patients tend to the same amount of time as allotted, but because I become curious more or less with the case when we get going into things, they tend to run over, and they can really create some backup throughout the day, and of course that adds more stress to the therapist and to whoever's kind of managing everything, and we try to run a pretty tight ship. So my last patient, what I thought they were coming in with, they didn't come in with. So to start off with my plan of action, kind of what they were suffering from was very different than what I was anticipating to kind of deal with. And I found as a therapist, I had to really shift gears very quickly and kind of figure out what that individual was going to need and what I could kind of do as far as bringing the most benefit to the time that I had with them. To top it off, this person was in town for literally that night. They were leaving the next morning, and a friend of theirs just happened to kind of get him in, sort of a thing. Interesting thing about this case is he had some interesting distortions, and we'll get into that, but this is going to kind of fall into that things category. Patients come in with a lot of different problems. They may be in a very, very different emotional states at different times. And in this particular situation, this gentleman had lost his son. I want to say he was at least 20, 25 years old. And I mean, it was a recent event, very shocking. Unfortunately, it was due to the opioid issue. The young man had some surgeries in his shoulders from a couple bad hits playing football, and maybe it was just the time, maybe it was the doctor, maybe it's a certain genetic predisposition, or maybe everything falling into place perfectly. But the young man was prescribed something, and he took to it too well, and sparked a bit of maybe something within himself as well that he couldn't pull away from, and unfortunately it led to his ending of his life. And to get a patient in who's went through a significant emotional trauma to begin with, it's going to be a heavy hour. They're usually dealing with a lot, not only physically. I mean, we all have these physical things, these dysfunctional patterns that we're dealing with, and things that need to be resolved that aren't. But then we also have these emotional and these mental things going on that feed into it all. And this was one of those sessions where I had to use a variety of tactics typically when patients come in that are in this way, they're going to get shaken up at certain points. They may start to reference, the person who had passed. They may have had a very emotional, or not emotional, but strong connection with that individual. And now that they're gone, they're going to be grieving that loss. And one kind of, I don't even want to call it a technique, because I feel like it's just human. Something I'll do when I have patients that are in that state is when they maybe begin down that doom and gloom path, I'll kind of call it, where they begin to maybe get too caught up in their thoughts in the moment. It's not right for the moment, or for the session, I should say. Who knows what moment's perfect, but if you can try to respect how they feel, but also try to continue on in the direction that you're trying to help that person, that's kind of the optimal thing you can do kind of at that time. And something that I've kind of used with this gentleman, and I've used in the past, is when that topic comes up, or when they begin to talk about it, and the emotional state begins to shift and they get more emotional, which does affect the tissue, does affect how your body's reacting when we're trying to treat you. Instead of, discounting what they're saying in any sense, or not knowing what to say, standing there awkwardly, we're not really trained to be human, but we're all connected, and there's a give and take that's always occurring, whether you want to acknowledge it or not. But when people stop giving, people notice. And one way to, I guess you could say, give to the situation is, maybe ask about positive things that they remember about the individual that had passed, or things that they were interested in. And in this particular case, this father just lit up, telling me all these things that his son was doing, and was aspiring to do, and was achieving. And what I began to find out was his son was close to my age, in a very similar field as my own. And I quickly realized that, certain patients end up in your office because you do good work, and certain patients end up in your office because they need to speak with you, or to be in your presence and kind of what you offer, and that may be in treatment and your abilities and techniques and things like that, but also in your personality, how you conduct yourself, what you represent, things like that. And I really feel like, this gentleman we never try to be counselors by any stretch of the means, but there's something to be said to just lending an ear, letting somebody vent, but letting them vent in a positive way, something that's going to be constructive, not something that's going to tear them down, make them weep, make them sorrowful, make them cry. We want to try to spark something in a more positive light, and kind of just shed a little light in the person's life. You have the ability to correct them physically and help them physically, and a lot of times we can be the crutch that someone needs when they're down, and in life we'll have our own down moments. So it's one of those things where you might as well just pay it forward now, so you got a little credit on the back end. To get a little bit more into the gentleman's kind of pain and what he had come in with, or basically seemed to, and were somewhat minor issues, some simple muscles that were attaching to the lower rib cage, rib attachment, or not rib attachments, but muscles that are attached to the ribs, and simply treating those, releasing his obliques, his lats a little bit. Things began to change pretty quickly, and his back pain started to improve. And worked on his hip a little bit, got some things to correct, but this was another case where, when I initially taken my measurements, he wasn't meeting the demands of the the Lover reactor, we call it. So basically his cranium and his pelvis weren't communicating properly. And part of at least my initial treatment when I see patients is if that mechanism isn't working, my first step is, hey, let's go correct that. So I began to do certain things during the treatment as we were discussing all the stuff on the back end, right? You're looking at these, but you're also having to juggle what else is going on. It could just be, someone that's talkative that wants to talk about their cats. It's going to happen. You just can't be silent and focus like a Jedi on what you're doing all the time. So you're going to have to be able to multitask. So as I'm trying to process and digest what this gentleman needs as far as, okay, I'm going to treat this muscle, and okay, his cranium and his pelvis weren't doing this, so I'm going to need to do this to get some certain things to shift and correct. We're going through all this, and I found that everything was working. Everything began to loosen up. Things were softening. He was noticing improvements. Not only that, his mood was improving. He got some things off his chest. Sometimes things are easier to be said to a stranger than the people that you're closest with. So I feel like, in a sense, certain things were said to me that he was able to just kind of let go of. And I feel for himself that was very freeing. And his body responded to that. So after all the corrections and everything had taken place, he was feeling pretty well. We had discussed, when he would be coming back. And one thing that I had missed, or didn't necessarily miss, but just kind of had forgotten about from the beginning of the treatment, was that, we had talked about, okay, so when you endure emotional stress, especially consistent stress, so stresses day after day, anxiousness, things like that, or definitely heavy traumas, deaths in the families, breakups, you name it. If you're going to take it to heart, so to speak, your heart is going to react. And before the gentleman had left, I said, hey, let's do, one more thing. I go, it was the end of the day. I knew I could take a little more time with the guy. I ended up running over like a half hour. I'm terrible. Usually never happens, but this was one of those cases where, homie just needed something. So we got him back on the table, and I explained to him what I was going to do. And basically to relieve pericardial stress and tension, we look for certain measurements to change from standing to laying down. That can kind of be the signal for it. But to treat it, you're basically doing a reverse kind of chest compression if we're trying to resuscitate somebody. So, you're pushing, down and in on the rib cage on the top, and then you kind of do the opposite on the backside. And what you do is you basically get to kind of get the rib cage to move much like an accordion. Everything just kind of, because of the angle of it all, as you apply pressure and you can direct that pressure, you kind of get things to compress and shift. And in doing so, you can begin to manipulate the lungs or the pericardium and things like that. And in this particular instance, I think we did about, 12 compressions, 6 on each side. Just basically trying to focus the pressure on the sternum, but directing the force not only towards his feet, but out towards his hip as well, a bit more lateral. And in doing so, it felt as if a couple things had mobilized. We don't do adjustments, but what many patients find with our type of work is when the soft tissue begins to correct, the structure knows where it should be. And the structure will move back to its assigned position if it can. And as we alleviate tension or soft tissue dysfunction in the body, and the tissues get healthier, usually joints are less compressed, less irritated, there's less inflammation, all that stuff starts to calm down, and things are usually willing to move much on their own. Many patients notice or will note that when they get off the table after a certain treatment, things are popping and clicking, and then, a day or so later it stops. And that's because the body is readjusting. Obviously, there's certain deformations that can occur over time, degenerations, things like that. I'm just talking about in general, if you can alleviate these tensions and decompress the joint, things are going to fall back into place. And that's what this gentleman was experiencing. But the biggest sign and kind of a benchmark of how I gauge how people respond to this type of treatment is I have them take a deep breath before, a couple deep breaths before, and I have them remember what it feels like to take that deep breath. And the biggest thing that people notice is when pericardial tension releases, or maybe when the lung tension releases, it's almost as if the diaphragm begins to want to function better, that things want to move, things aren't so rigid, and you find that you can inhale and take a much, much deeper breath. And immediately you could, just almost kind of see him swell up inside. He took this deep breath, and you could see it in his face. He felt it. He felt this relief, this pressure fall off of him. And I think it's something that we look at it. I've never met another practitioner and, consider just the Western field, that look at, your heart's, maybe there's some tension around your heart. Immediately people are, stroke, heart attack, You go through the list of, what cardiac problems could you potentially have. And nobody cares to think about, heartbreak, breakups, deaths in the family, traumas, PTSD. People carry this stress around, and who knows how long this gentleman would have carried it around if he didn't luck out and land this appointment, that we could resolve this before he flies back to the other side of the country. The guy lives over towards the West Coast, and to be able to serve somebody that way, to help that person, even in the smallest amount, even if it helps him get a better night's sleep, because hey, we reduce some of his overall pain, and we were able to take some pressure off his system that in the long term would just continue to wreak havoc. And I know it would continue to wreak havoc because we measure things. And one thing that I rechecked after we had done this, and he had taken some breaths, and we had talked about the importance of this, and I educated him a little bit more, and he was just kind of really blown away at how he felt. And oftentimes when you can do pericardial compressions, you will find that people will enter a state of somatic emotional release, may begin to cry, things like that. And he was definitely on that kind of general path. And once things had settled, I asked him to stand back up. One of the primary things we look for when they come in, any new patient comes in, we look for leg length inequities and things like that. And he had a bit of a pelvic tilt, and his shoulders were tilted, and his head was off. But like I had mentioned in the beginning, that Levitt reactor system, how your cranium and your pelvis are compensating or working with each other. It wasn't cooperating. And because it wasn't cooperating, I wasn't going to be happy potentially putting something or recommending to put something in this gentleman's shoe that could potentially hurt him down the road, right? That goes against what we do as practitioners. So I put him back up. I remeasure him. The tension that was lingering in his chest, that was pinning his chest down, changed his cranial measurements entirely. So much so that his cranial measurements then begun correcting properly for the way that his pelvis was compensating. He still had a leg length inequity. He still had a previous knee injury. I explained this to him a little bit more, that we weren't going to address the leg length until I'd see him in the future. The last thing I'm going to do is put somebody in a lift and send them out of my care, to send them into another state or on into whatever avenue of life that they're going to be segueing into without my guidance as they move into this new phase, this new chapter, this new position that their body's going to be adapting to. But the testament of just releasing that tension, to taking the extra time, to recognizing, hey, I've done a lot. This treatment in general has been a lot, but there's still a little bit more that can be done. Are you willing to make it happen? And this was one of those things where in the midst of it, it seemed very heavy, like, Not that I was waiting to get to the end of it. It wasn't nearly that that bad. Um, but when there's heavy emotions around, they're heavy in general. They weigh your body down. They weigh your mind down. So I was more so, looking forward to that kind of relief. But to take this extra time with this gentleman, to get the corrections that we did, and to send him on in such a better way. Not only did we kind of unload some emotional stuff, but we got his body to correct more efficiently, so that he could at least go back, enjoy time with his wife, enjoy trying to get back into some sort of normal routine. He's got enough on his plate, if we can at least shave off a couple of those numbers on that pain scale and get some of his dysfunctional patterns under control before he has to walk back into the next battles of his life. I mean, that's what it's about. You're not gonna win them all. Not every patient is going to be able to be corrected 100%, etc., in a single treatment, and you really have to prioritize, and you have to really focus on, what are the essentials of what I really kind of want to get done today, and what's going to make the biggest impact, what's going to help the most. So I had a couple questions that I just kind of wrote down for myself in regards to that, because I know there's a lot of therapists that they kind of ask the question of, when is it proper to give more, where are boundaries, what about, the power differential between you being a therapist and them being a patient. And you have to take all those things into consideration. You also have to take your personality into consideration. I, in myself, have always considered myself to be a giver. And as I've come into manhood, I've begun to realize that if I could be anything, I would want to be, the tree for life, to be able to expand, to be able to grow, to be able to withstand the storm, and to be the shelter and the stability that others need when they need it. And not everybody has that in their path. Not that you should, to each his own. But as much as I want to give, I've learned to pick and choose where I put my energy, and you will have to do this regardless of what you do in life. And this was just one of those occasions where I decided, hey, I have X amount of energy left to give, and I'm just going to let it go. Just going to give it up. And in hopes that if, maybe I'll feel more gratified, maybe I'll feel more fulfilled in some way. But if nothing else, that I at least attempt to make an impact in someone's life in a positive way and send them away from our experience in a better state than they were when they entered it. Now, you don't have to do these things, like I said, but for me, I've found this was kind of why I got into this field in the first place. And it's very fulfilling when the opportunity arises, when someone truly appreciates everything that you've done. Like, you can, in your core, you can feel this person put that energy out, that, they've appreciated everything to its utmost, which is pretty awesome. So yeah, segueing on, I want to say it was the next day. Next day, I had a new patient follow up, and she had some positive changes, and some things she had noted were better, but then, a couple days later, they started to get worse. And we find this, or hear this a lot, that, hey, it was good for 2-3 days and it gets worse, or, it was getting aggravated again. And we kind of have a principle of, fixed patterns and patterns that will change or switch. And for the most part, the average therapist, 3-4 treatments can break up a fixed pattern. So if your shoulder's elevated for some reason, within about 3-4 treatments, they're going to be able to chisel that down as to, what's causing the elevation, what muscles need to be treated, what's the primary focus, etc. And this was a case where we were working on the nerve pathways basically through her arm. She had some birth defects in 2 of her fingers that were deformed. I believe, had done some skin grafts too. There's basically a lot of hypersensitivity in the area, things like that. And as we were kind of going through, I guess, the consultation portion of all this, we had done some measurements, and I was viewing her chart from last time and the one from this time, and looking at what I treated and what changed and what was improving for the better and maybe what had gotten a little bit worse. And it was the perfect model, you could say, for when you should be, like when documentation works at its finest. To be able to have the notes, to have measurements reinforced, to have your own notes, your own thoughts jotted down on a piece of paper or electronically, like I use a tablet. Anyway, it doesn't matter. But to be able to go back and reference that, I swear one of the worst things that I did in the beginning of being a therapist is I didn't use a chart. Or I did, but I just half-assed it, You discount the significance of taking all these measurements because there's a lot. And you're looking at them all and the dynamics and how they're all playing off of each other and how the body's correcting. And it's just a lot of information to take in. And what I realized is it was so much information that my brain couldn't quite process it. So I started small. I started looking at a single distortion, and then I'd look at 2 distortions, and I'd look at 2 relative distortions. And I would try to remember the muscle patterns and remember how the body would be behaving and what else could be going on. And, okay, well, if I release this and then the measurements change, where do I go from there? And to an extent, I feel like not doing certain things helped because it helped my memory, helped me process things better in my mind, kind of better dissect them and figure out exactly what's going on. But at the same time, I can't discount the good old-fashioned notes on, hey, you were doing this, and now you're doing this, and this is why. And you educate that patient, and you help them understand what they were doing, why they're doing something different, or why they reverted back to an old pattern, and you got a patient for life. Because patients don't get educated that way when they see their normal doctors. They don't get educated that way when they see hardly anyone. There isn't an opportunity where you have an intimate moment of your day. For us, we have an hour that we spend with patients where, you're not here to get a skin rub. We're here to fix some stuff, So you're going to stand up here. We're going to take some measurements. We're going to talk. You're going to learn something. And when you leave, not only are you going to feel better, but you're going to be better empowered and you're going to be more knowledgeable to not go jack yourself up in the future. And if you do, you're going to understand what you did, and you're going to have suspicions of why it happened in the first place, and you're going to come have it addressed much sooner than you did in the past. And you're not going to have the same lingering bullshit problems that keep coming back time and time again. So this lady was awesome. I sat there, explained everything to her, said this is what was going on, this is what you're doing today, this is where my head's at, this is what I saw, this is what I was anticipating, and this is what I want for you to today. And I'll tell you, you could talk until you're blue in the face trying to sell somebody on something, but if you can explain to them why they're doing what they're doing, and you have a couple notes on a little sheet of paper, it blows their mind. Because the last person that told them something sent them to a specialist. The specialist sent them to an MRI. The MRI place sent the report and the disc back to their doctor's office or the specialist's office. They had to go back to the specialist's office. This guy then goes over what the report says that somebody else printed out he barely even looks at it, and there's no education. They're just like, oh yeah, that's broken down, or oh, you got some arthritis. Garbage. X-rays, MRIs, all beneficial when utilized appropriately, but degeneration, things like this are not the sole culprit of pain. Things get to that state due to ... pelvic imbalances, traumas, misuse, overuse, these patterns, this dysfunction that forms in the tissues that basically wreaks havoc on everything. Nobody looks at it. So for me, it was just a nice little gentle reminder that, hey, although you're getting older, you're understanding things better, there's still such a value in the basics, of breaking down, hey, you're doing this, this is why, and look, I can show you why, because I gave a damn enough to document it. So that's all I have to rant about for Jardy. All right. So my Tuesday patient, or my last Tuesday patient, was really awesome. This patient was sent to me by another practitioner, and I can easily say she is a sweetheart of a person. She has literally been through hell and back, and still has her smile on her face about it. And the short of it, and I think this may have come up in another podcast or another episode as well, but this patient, or this woman, was in a very, very traumatic car accident. Severe pelvic floor damage, organs torn away, things had to be reattached, part of her skull had to be reconstructed, literally been through hell and back. And one of her biggest problems, and it's been kind of like the number one on the list from day one of, we can't get to the other stuff until this starts getting resolved, is back pain. And this was a case where, I was pulling out the big guns, thinking it was organs referring into her back, or, maybe there's some scar tissue, or, as a combination of both. Did, fascial work, did some lymphatic work, went back, tried new things, tried different muscle groups, rechecked certain muscle groups, and we'd make progress, but then it'd slip back. Make a little progress, it'd slip back. And I don't know what kind of struck a chord the other day, but she had come in, and some things we had done the week before didn't help at all. And that's discouraging, when you have an hour with somebody and that's the only hour you're going to see them for maybe the next week, 2 weeks, 3 weeks, 4 weeks, whatever the case may be. You want to try to create a positive benefit. If they have a lot of things going on, you may not be able to help all of them, but you might be able to knock one out of the park, or maybe improve them all by 20-30%. Who knows? In this case, we had focused on her spinal erectors. We had worked on them a bit in a previous treatment when she was having some neck issues and things like that were really bothering her that day. And I went back again, boom, looking at the charts, referencing what I did before. I saw, okay, I did this and I did that. And then the following treatment, we had done more of the spinal erectors, treated a little bit better around the attachments, made sure I got the full length of them, did a little more drier work, didn't use so much lubrication just because you don't get as much stretch on the skin and the fascia underneath. And that's when I found that she realized, or she, didn't really get much relief from that. So to me, that was a biggie, because I was, it had helped the time before. So what changed? And basically one thing that I found, and we notice this a lot with leg length inequities and things like that, but definitely I would say in general, men with their lack of hip mobility and their tucked butts and their flat backs and not giving a damn about what their lower body's doing, we'll usually find that, the lateral side of the hip, the side of the hip is actually in such a contraction, so locked up that it's almost like a steel bar, welding the top of your hip to the top of your femur. And it limits the ability for you to flex your hip as easily, and it just creates a lot of rigidity and causes tilts and causes back pain and all sorts of junk. So I had thought about something that we had talked about from the beginning of her coming to the office, and that was, the significant surgery where they opened up her abdomen. So I go, okay, we're going to try something different. I believe what I treated last time was on the right path. I think it's helping. I think something else isn't letting go. And when we get the front to back stuff corrected, flexion, extension, we got to look at the tilt. What's going on in the tilt. And sure enough, her left hip was locked down. Just palpating it gently. It was on fire. I got her back on the table, kind of bolstered her correctly, and started looking around that area. I mean, the slightest amount of pressure was really severe. And what I'd kind of realized was from the extensive surgery she had in her abdomen, they had made such a large incision, the incision was actually stretching over the side of the hip. So when the sutures and everything began to heal, a certain amount of scar tissue had built up in that area, and it had bound to the fascia that was wrapping around her gluteus minimus, TFL, things like that. As it was healing, which also means it was thickening with any scar tissue or adhesions being laid down with the inflammation that's lingering, the entire area just became more and more dysfunctional. And this is just a theory, but what I think may have happened, because I find this pattern in nearly everyone who drives, is when she was in her car accident, I believe her left leg was bent. Most people, there are a few that don't, but most people will drive with their left knee bent, leaned against the door, slightly adducted or abducted. And when left in that position, especially day after day after day after day after day, the tissues assume a repeated pattern. So we kind of fall into that overuse overuse category. And as that muscle repeats that, it gets tight in that position because your body's going, oh, you keep doing this, so you want us to do it better, because that's what your body does. And when she was in her car accident, she was hit by a drunk driver, or actually she was on a gentleman who was high on heroin. I believe because the leg was hip flexed in that position, that when she endured the trauma, the tissue spasmed, because as in any trauma, or when your body feels assaulted or fearful, you will tense up, fight, flight, or freeze. And as she froze, the tissue held that position. So after everything they had done, the muscle was tight, the fascia around it was getting tighter, and then they make these incisions. Now the incision is healing over all of this traumatized tissue. And basically, we spent a good amount of time on her hips, just gently working, 20 grams, 30 grams of pressure, just trying to get enough traction on the skin where I could get the tissue to begin to release and the adhesions to begin to release, lengthening the scar long ways, not trying to pull it apart, trying to unbind it from some of the the tissue underneath. And after a while, it began to soften. It got softer and softer. Then I was able to do some deeper holds that were a little more intense, but I'll tell you, they were effective. They got the tissue to begin to let go, so much so that as we were going through, I'll call it the phases of this, because it really took a lot of time to nurse. This wasn't a case where I was going to take care of a shoulder problem, a neck issue, and a back issue all in one treatment. No, we're focusing on this one thing. And I'll tell you, it paid off. When we look at the hips and what certain muscles do, muscle action's one thing, but when the structure is static and standing still, that's kind of what we base our measurements off of. So if a hip is higher or a hip is lower, certain muscles will cause that hip to elevate. Certain muscles will cause the other hip to depress. Same with rotation. Certain things may drive a hip forward and cause a rotation, and you could have maybe the same muscle, a similar distortion on both sides firing, causing a bilateral projection, or maybe a little more tense on one side and causing a bit of rotation. And as you eliminate that rotation, the rotation emerges on the other side because the other side maybe maintained about 50% of what the other one did. And basically, as we release the side of her hip, her depressed side of her hip, or her left side that she would have had bent during the car accident, that began to let go. And as it began to release, I'd have her stand up and walk around and, do little things that were typically very difficult, very hard to do. And surprisingly, very, very, very quickly, she was bending over, touching her toes. She had a pattern of wanting to push off on her knees to almost kind of like rocket herself up before her back had to engage to try to, keep her or to erect herself upright. And she did that a couple times in the beginning, but after we discussed it and I explained to her that was just a pattern she had developed and that she could break it, sure enough, we did a little more work. I tried to get it to loosen up a bit more while we still had some time left in the treatment. And it did. It opened up a bit more. She kind of overcame that thought process of wanting to push off on her knees, trying to bend over and try to, get herself back upright again. And she was bending up and down, no problem. So to kind of go back to the beginning of this whole case, I mentioned spinal erectors and how I treated those sorts of muscles around the spine that help kind of support you upright. And I had confidence in myself that I did a good enough job on those that wasn't the culprit. So I could have easily pissed away that treatment, going back through, retreating that, thinking that was maybe the problem, or maybe getting a little more creative, thinking it was a little bit of this or a little bit of that. And instead it was something that was present. It was a little harder to measure, just due to the patient being overweight. And that's common. A lot of people, especially when they've gone through something like that, they put on weight due to being in the hospital and the downtime, the recovery time. But I would say as a practitioner, someone's weight shouldn't defer you from being able to do your best job as a therapist. Some things may elude you. You may not see them as clearly, but sometimes you have to act in faith or off of what you believe may be happening, or what may seem slight, but slight in your eye at the current moment could actually be fairly significant later on down the road. And that's kind of what I was finding, is something that I had considered to be slight and not a huge difference ended up being very impactful for the patient in a positive way, and getting their, the pressure off the back. A lot of people call the pain she was dealing with, SI joint dysfunction, kind of a very broad term that really nobody, it's, what's dysfunction, Is it falling apart? Is it pissed off? Like, what's it doing? And the short of it is, your SI joint is a mobile or is a stable joint. The hip has a slight ability to flex and extend, and it has the ability to inflare and outflare. Not much, but it has to do it in partnership with the other hip as well. And because it's being forced to cooperate with the other side, when one side has to make a compensation, it can oftentimes bind up the other. And the other pays the price regardless, just because it's part of the scenario. It's part of how the body is actually balancing itself. We forget that our body is programmed to us being in the wilderness, trying to survive, trying to keep you mobile and moving. Your body doesn't care about a career or what kind of car you drive or anything else in between. Its objective is to adapt to your patterns. So if you have terrible patterns, it's going to adapt to your terrible patterns. And if you can understand these patterns or understand where the dysfunction's coming from the patterns that you've created or you assume daily, we can understand the muscles that create them. And by treating those muscles, getting the tissues to release, getting the tissues healthy again, the distortions go away, the dysfunction goes away, and things like SI dysfunction disappear. Because the only reason they're present in the first place is because something is being pulled or moved in a direction that is causing some sort of agitation. So in our case, or in our kind of modality mindset, I'm not really worried about your SI joint. There's nothing that I can do to change the integrity of your SI joint. What I do have the ability to influence is what the bones attaching around the SI joint are doing. Are they tilted? Are they flexed? Are sacral ligaments tight? Is something that's supposed to be tight on this side is also tight on the other, or is something locked up that's causing something to bind up on the other side. So this was, after a heavy start to the week, Tuesday was a nice reprieve, to have a kind of a cool case in the middle of the day. Somebody had been doing well, but I also got to teach a little bit too, a bit more than I do, some of my other patients, and to then finish the night off with, what's been a bit more of a long-term patient, and really having some successes that I believe are going to really turn her 2020 around. This is 2 weeks into the first part of the year, and I think this is going to be big. This, I believe, is going to be that hurdle we needed to get over to progress into the some of the other dysfunctional problems, other areas that she wanted to also address that before seemed insignificant, or throw them on the back burner. But hey, I'm pleased with what I found. I'm pleased with the results that we got, and I'm just grateful I can share some of these experiences and hopefully enlighten some people that maybe have some similar issues or have been through some similar struggles, or maybe some family that's been through that. It's good to know that there's hope. There's something that can change, and that just being grateful there's patients that are willing to continue to put in the time. A lot of people give up too soon. They aren't willing to put in the time and effort to really see it through, and many times, if they would, it pays off, and it pays off big. So I think we'll wrap it up for this week. Next episode should be really interesting. I am going to dive into a little neurofeedback that I've been doing and experimenting on myself for a while, maybe a longer one. I'm going to kind of dive into, how they did the initial scan, what came up, some previous things that had happened in life that I should say my brain remembered. I did as well, but physically there were marks left, and how we went about starting to correct those. So I'll be going for my last mapping tomorrow on Thursday, and it should be really interesting. I'm really curious to see what's changed, and I hope there's some good changes. I feel like there's been really good changes, and I hope that we can just measure them so that I can better convey what has helped me tremendously with neurofeedback, but also try to break it down in terms that people understand something great about the type of work that we do, and for myself, having done it so long, I understand it better now, and it just gets better and better. It's like a fine wine. I see things that I didn't see before, and I see patterns that I didn't see before. And when, I do certain experiments with myself, I find certain things changing for me that they maybe look at in a certain light, and I look at in a certain light. Or maybe they explain something a little bit better, or vice versa, and I can help regurgitate that to help people better understand, the benefits of some of these things. We have a great potential to influence the outer structure, the organs, the viscera, manipulating cranial bones, creating a lot of powerful change in people. But one thing we can't quite do is get that neuroplasticity restructured, recalibrated, reordered, so that the chaos calms down. So we'll dive into that a little bit, or a lot of it, in the next episode. So I appreciate y'all. Hope you're enjoying these, and hang in for the next one. Thank you.